Hi, my name is Pia Tuominen and I'm here today for the third episode with Professor John Reed. Nice to be here with you, John. And we are going to be creating this episode about psychiatric diagnoses in our series, Challenging the Medical Model of Mental Health, a call for humane evidence-based services that respect human rights. And it's an absolute pleasure to be here with you again and talk about these important topics.
Lovely to be here. I'm just turning it up a bit. Yeah, excuse me. Yes. Yeah, no, lovely to be here. Happy New Year to everybody. Bit late, but there you go.
Yes, same from me. And just as an introduction, if someone doesn't know you, you're a professor of clinical psychology at the University of East London and the chair of the International Institute for Psychiatric Drug Withdrawal. And I'm a former psychiatric patient, a solution-focused brief therapist, and a multi-passionate person. And I like to use especially blogging, illustrations, and my podcast to challenge the mainstream views of psychiatry, because I think there's a lot to talk about. How could we do things better and help people better and think about these things differently? And that's what we are doing here, to discuss these issues and to give some alternatives and ideas for people. How could we move forward in a better way? But today, the psychiatric diagnosis is our topic, and I was thinking I could perhaps share a bit of my own story to use as a starting point, because I've mentioned before that I've withdrawn from the medications like multiple years ago. Actually, it'll be 10 years that I'm off medication at the end of this year, so quite a long time ago. And I started withdrawing from the first medication by myself because I didn't get the psychiatrist to agree with me to withdraw me from the medications, because he was very concerned that with this diagnosis that you have, it's probably not a good idea to withdraw from all the medications. And that's why I decided to do the first bit by myself. And then I went back to him to talk about the withdrawing from the rest of the medication and requesting him to create me a withdrawal plan for those medications. And again, we had this discussion, like it's not very good idea with this diagnosis. My diagnosis at the point was schizoaffective disorder, and it had been that for multiple years already. And I ended up giving him a kind of a mini lecture about how the diagnostic system in psychiatry was created, what I know about the history of psychiatry, what I know about the history of this system, and how it got created. And basically, I told him that I know about some of the issues we have with this diagnostic system. And after that mini lecture, he said to me that, well, basically, psychiatry is not an exact branch of science, and the patient can get 3 different diagnoses depending on who they see and at what point of their illness or at what point of their journey. And it's true that this diagnosis that you have is kind of a junk drawer or a junk box of psychiatry, that quite often when nothing exactly fits, people get this diagnosis. And I was stunned. Like it took for that mini lecture and me sharing what I know about the history of psychiatry and the history of this diagnostic system before he ever said anything about, there might be a point, like what you're saying in wanting to withdraw from the medications. So perhaps we could use that as a starting point. What do you see are we can talk about the positive sides of psychiatric diagnosis and the negative sides of psychiatric diagnosis. What alternatives do we have? But where would you like to start?
Well, yeah, that's an interesting story, Pia. And I think it's fairly common for people using the diagnosis not to acknowledge that they're very inexact and subjective, and that was very, very good of the psychiatrist to acknowledge that you will get a different diagnosis if you see a different person very often. But as you say, most people are not told that. They're just sort of given a diagnosis as if it was as reliable and valid as most medical diagnoses, and they're just not. So you finally got a bit of honesty, but it would have been useful for you if you got it earlier. And it would be useful if more people heard that honest sort of account, that they're at best approximations or guesses or ideas about what might be going on. But we should probably, when I lecture students on psychiatric diagnosis, I always start with the positives first, because there are some, and there are reasons why doctors and some psychologists and others use diagnosis. And the basic idea, I guess, is that if you lump lots of things together and call them something, then you've got a sort of some sort of category. You've got a shared language, I guess. So then if you call lots of, stay with my own area of psychosis, if you call hearing voices and having paranoid ideas and thought disorder and all these things, and you can either look at them individually or you can group them together into a category and have a word that everybody knows. That's what that collection of things is. So you can do some research, for instance. So because if you want to do research into like what's called obsessive compulsive disorder, you need to know that that we're grouping together a whole bunch of things, like repeatedly washing your hands or repeatedly having to check that the door is locked before you leave the house. You can't, if you look those things up individually, you're not going to get very far. But if you look up obsessive compulsive disorder, you're going to find heaps and heaps of research because everybody else is using that term. So I guess in a long-winded way, I'm saying it's a shared language, which has some advantages. And anyway, the human brain can't help itself but categorize. That's what the brain does. It puts things together and calls them something. So it's kind of inevitable. But in this field, it's very important that the things we put together are actually things that belong together and actually help us. And the idea obviously of that process of coming up with a diagnosis, as in medicine, is to identify two major things: the causes, and perhaps more importantly, the treatment. But that's the point of doing a diagnosis. And the question is, do psychiatric diagnoses do those things? And I'm going to argue that by and large they don't. But let's stay with the main positive, and apart from just the categorizing and the shared languages, it creates a diagnosis creates I think it's an illusion, but it kind of creates an explanation. So when we go to the doctor and describe our symptoms, whether that's let's say some physical symptoms, medical symptoms, the last thing we want to hear is, "Oh dear, I don't know what that is." We don't want to hear that. We want to hear, "I know what that is. It's this. It's ABC disorder or whatever it is," and that can be a great relief, especially in the psychiatric, where the area of mental health and distress and so forth, to hear that an expert has listened to you and then says, "I know what that is." That means that other people have got it, so you're not alone. Hopefully it means that she or he knows what to do. And they've seen it before and they know what, they have some idea what to do. So it can be quite comforting to get a diagnosis. Very often parents are very comforted when they get a diagnosis for their child. But we can come back to children's diagnosis later, perhaps. But so it can be comforting and a relief, and thank God now I know what it is. And it can suddenly start explaining all the difficulties you have. Now I know why I do this and why I do that. I didn't know before, but I thought maybe I was just a bad person or a really whatever person. But now it's because I've got this disorder. In fact, I teach all my undergraduate students to come up with their own disorder, to invent one for themselves, so that they can, for the rest of their lives, explain away anything stupid or self-defeating that they do. And I say, my diagnosis is Squirkly Bob disorder. And the reason I know that I have Squirkly Bob disorder is that I do the sorts of things that people with Squirkly Bob disorder do. And I do lots of silly things, and every time I do something really silly or offensive to other people, I can't help it. I've got squirkly bobby sore, so I encourage them to come up with their own diet to try and illustrate them. It's a bit of a silly thing, but seriously, people do feel a lot of relief very often, especially in the short term. A lot of the research suggests that people find short-term relief in the diagnosis, and sometime down the track later on discover that it has a whole lot of negative side effects, which we can come on to. But let's acknowledge that it can be very helpful, especially when you're very distressed and confused. And in the short term, it can bring quite a lot of relief, I think. So it's quite an attractive thing, because partly, apart from anything else, it means we haven't got to think very much about what I would suggest are the real causes of our difficulties, which are often upsetting things. So it's comforting because you've got an explanation, but it's comforting in as much as you haven't got to delve into things that are somewhat unpleasant. So those are the good things about it. I mean, if I can just briefly list what I think are the main disadvantages, and then we can go back into some of them depending on what you think would be. So just to list them without discussing them, there's the scientific stuff about the reliability and validity of these diagnoses. There's the fact that they put people into categories whereas actually human behavior exists on dimensions. There's the fact that it locates the problem entirely within the individual person rather than that context. And therefore sort of implies a sort of medical cause and illness type perspective. And the other main one is that it leads to stigma. So those are the main areas that I think we need to be concerned about. Now, I don't know if we want to jump into any of those first. Do you have a view on, or do you see any others, Pia? I mean, you've been through it. You've been on the receiving end of these. Are there other disadvantages that I haven't thought of, or advantages that I haven't thought of?
I think the couple of things. These are not perhaps like anything new or anything to add, but just a couple of points I'd like to make. Well, first of all, the kind of a relieving effect at the beginning when you're getting a diagnosis is very understandable, because the assumption, I think, for most of us is that like there's science behind this. Like there's this, now they know how they can help me. Now they know what's wrong with me, and now they are able to help me. And it can be very comforting to know that, okay, that's what's wrong with me. And it only becomes clear perhaps for people after many years or decades that it's not as a truthful concept that people assume, because we don't have anything objective to rely on to like check if that's true, like if these are not same kind of categories than other diagnoses in many other diagnoses in medical model or medical field. So one of the issues that we have, I think, is that after we are giving people this kind of a diagnosis or label, it's a very powerful lens that we look at the person through. And it's such a, like, I'm sometimes imagining like a kind of a, I don't know what's the word in English, but there are these like amusement parks. And there's sometimes there's this kind of house where there are mirrors that distort and make all kinds of like funny effects. And
we call them the house. We call those the house of crazy mirrors.
Yeah, house of crazy mirrors. Yeah. Well, I think this diagnosis can like operate as a kind of a crazy mirror, because even like very understandable reactions, even very understandable things start to become kind of twisted if we look at them through the lens of psychiatric diagnosis. And one of the most unfortunate things, I think, is with these diagnoses is that, especially with certain diagnoses, the doctor that is sitting in front of you can seem to like look at you like, can I believe you? Like, are you telling the truth of your experience, or is there something like distorted in what you say? And even like normal things that we talk about. For example, with my friend, we've been lately talking about spiritual things and like all kinds of like philosophical ponderings and like weird things. It might be weird in that context if in front of you is a psychiatrist. He might look at you differently if you talk about those things versus if you talk about those things with a friend or in a totally different context without that diagnostic lens. And I think that is one of the main issues, like I feel with the diagnosis, is that we're not hearing the person same way. We are not seeing the person same way. If we take those psychiatric diagnoses as a fact about that person. And that's one of the just something I'd like to add about that.
Yes, it can distort our perceptions of the person, and that process even begins in the diagnostic process, because someone who's trying to do a diagnosis, if you're telling me your story here about what's going on or what's upsetting you at the moment or whatever, and my job is to do a diagnosis, I'm not really listening to you. I'm listening for the symptoms in my little checklist. So if I'm trying to decide you have schizophrenia or not, all I'm listening for is there a hallucination there? Tick the box. Is there a delusion? Tick the box. So I'm not hearing the content of what the voices are saying. I'm not hearing the content of the unusual ideas. I'm not hearing what's going on in your life. So it starts there, and then once you apply the diagnosis, yes, absolutely. Or someone with a diagnosis of schizophrenia, if they get a bit upset about something, that's possibly the schizophrenia. Or actually, they can't win, because if they don't get upset about something, that's also a symptom of schizophrenia, because that's negative symptoms. So yeah, and so I guess if you've got anxiety, diagnosed with anxiety disorder, anytime you get a bit anxious, that's the disorder coming back, rather than, well, anybody would be anxious in that situation. So yeah, so I'm just agreeing with you in a long-winded way. So yeah, so it can so it can be kind of hard to get rid of, to move on from it, because everybody's now seeing you in a certain way. Yeah, but should we talk about one or two of those disadvantages in a bit more detail? Can I talk about the category thing first of all, which I said to begin was kind of an advantage, and this is one of those that's an advantage and a disadvantage, because we can't help but categorize. But the problem with human behavior is that we're a bit too complicated to fit easily into boxes. So if we take depression for an example, it's not like there are some people who've got depression and the rest of us haven't. And then this is not depression, like any human feeling, is not a category, it's a dimension. So with any day, even, we'll move up and down. If there's 0 to 100 on a depression scale, we'll move up and down on that scale within a day, certainly within a week, and within a month it'll be a bigger range. And it depends on what time of what day someone asks you how you're feeling. So if you do a real assessment of depression versus a diagnosis, you should be asking, what's the worst you felt this month? What's the best you felt this month? What was going on when you felt so low on that Tuesday? Because there's always, the why now question is much more useful than a diagnosis. But once you put someone in that depression category, you're just missing so much. They're missing their capacity to not be depressed, or the fact that they're not always feeling down. They're feeling down usually when depressing things happening. But so we don't fit into categories very well, and putting someone in a categorical box can lock them in there, as partly because of the reasons you were saying before, because people see you in that way. So someone with a diagnosis of depression, or their family knows that they've got depressive disorder, if they feel sad about something, oh dear, Uncle Johnny's symptoms are coming back. No, Uncle Johnny's just feeling sad because something sad happened. So that's a problem. So we need to focus on dimensions, not categories. And sort of related to this is that other thing about how it locates the problem entirely in the individual. So Pia has got this thing, or John has got this thing. It's inside him. It's not in his social context or in his past or his childhood. It's in him now, and that is what's causing the problem, and that's where we get into this backwards circular logic. Why is someone depressed? Well, John has got this thing inside him called depressive disorder, which causes him to be depressed, which really doesn't make any sense. But it's the illusion of, okay, yes, I've got this disorder that makes me depressed. But actually, it doesn't actually explain anything at all. It's a circular logic. But more importantly, it's located in me. So it's not, the problem is no longer located in all the depressing things going on around me. Like at the minute, for instance, we were talking before we started recording about the state of the world at the minute. I mean, anybody who isn't a bit depressed and a bit worried at the moment about the state of the world really is not in very good shape. Or maybe they found a way to defend against it. You know what I'm saying? I mean, how can you not be a bit depressed at the moment, given what's going on? So that's part of the problem with diagnosis. It locates it all within you. And I remember, I think I mentioned before, I can't remember, I was 20 years in New Zealand, and Maori people, they just could not understand how us white people, when somebody got mad or really depressed or suicidal, we take them off away from their family and talk to them individually in an office, and then nobody can be told what went on in that room because of confidentiality, which makes sense and what happened. Well, because they do exactly the opposite. When somebody gets really distressed, they gather together as many people as possible in their whānau, which is called extended family, and say, what is our problem and what can we do about it together? And they just don't get this. What are you talking about it? How can you understand what's going on in a person's life by ignoring everything that's going on in a person's life? So, yeah, so that's the individualizing, which makes you miss all the social context, and also has this implication that you are disordered, you have an illness. And the DSM, the Diagnostic and Statistical Manual, which we'll come on to, I'm sure, says that it doesn't have a position on causation, it's neutral on causation, but it talks about symptoms and disorders. It's clearly trying to position these things in a medical framework. And my problem is that I don't think these things are medical phenomena. And you mentioned before that there's no way to test for these things. There's no biological marker for anything in the Diagnostic and Statistical Manual. If you get a proper diagnosis in the real world of medicine, there's either a blood test or a scan or something, usually, not always, but usually. There's nothing in psychiatry. There's no blood tests or anything to confirm these ideas that they have, these words that they use to describe us. So those are the sort of some of the main problems. I mean, we should talk briefly, as there's a boring bit to all this, the science bit of it, which the doctor that spoke to you finally did acknowledge that there isn't a lot of science there. So if I could just briefly talk about reliability and validity,
Yes.
I'll try and be brief because it does get a bit dry, but reliability of a construct, whether that's schizophrenia or depressive disorder or PTSD or ADHD, we might come on to that later, for it to be a reliable construct, different people looking at somebody have to be able to agree whether they've got it or not. So, inter-rater reliability or whatever, there's different terms for it. But so if you have 10 psychiatrists or psychologists listen to me talking for an hour and then try and decide what diagnosis I've got, you need 8 or 9 of them need to come up with the same diagnosis, seven. In psychiatry, when they do studies like that, it's usually there's about 4 or 5 different diagnoses between 10. I mean, the reliability for these constructs is very, very poor. It's not really good enough to be seen as scientific constructs. Just because different doctors and experts are using very subjective criteria to decide who's got what. So that's reliability. And then there's this other thing called validity, which is if someone if it's a valid scientific construct, the thing ought to have the characteristics that you say it has. So in a diagnosis, it needs to predict the future, tell you what the course of the thing is, or not illness, because it's not an illness, but whatever it is. It ought to tell you the causation. It ought to tell you treatment responsivity. So does everybody with this diagnosis pretty much respond well to drug A or psychological treatment B or whatever? And these diagnoses have very poor validity as well. They do not predict the future. Again, just very briefly take one example, predictive validity. From my own area of schizophrenia, it has no predictive validity at all. There used to be an illusion that everybody with this diagnosis ended up in very, very bad shape, and there was 90 to 95% of people end up really bad. It's not true. The outcomes after you get a diagnosis of schizophrenia are completely varied. I mean, some people will hear voices once or twice and that's it. Some people will hear them 3 times a week for the rest of their life. Some people come in and out of those sorts of experiences. Absolutely, completely varied outcome. So bottom line, they don't have reliability very often. They don't have validity, which means they're not scientific constructs. And more importantly, they're not useful in terms of predicting anything or telling you what the causes are that need to be addressed. So they're not really helpful. Just one last example, and we can move on to something else. Again, in my area, to get a diagnosis of schizophrenia using the Diagnostic and Statistical Manual, which is this great big thing here, which we can come back to. It's like the Bible of psychiatric labels, I guess. So to get a diagnosis of schizophrenia, you need 2 out of 5 types of symptoms: hallucinations, delusions, thought disorder, negative symptoms, and catatonia. So the problem with that is probably quite obvious immediately. So you, PSA, let's say you've got hallucinations and delusions and nothing else. I've got catatonia and thought disorder and nothing else. We have nothing in common, but we have the same diagnosis. This in science is called a disjunctive category, and in any other science other than any other discipline other than psychiatry, it would just be thrown out immediately because it just doesn't mean anything. So that's my short version of that's actually probably a 3-hour lecture well done properly. But I think people should be told what you were told eventually. Well, I think people should be told up front. Look, these are not really scientific constructs. They're just attempts to sort of summarize things. They're approximations. Don't get too caught up on them. Better still, I wouldn't use them at all, but we'll come on to that. But if you're going to use them, be honest about what they are, and don't give people false impressions that these are tight scientific constructs with biological causations that we can demonstrate, because none of that is true. So
Yeah. One of the feedbacks, or perhaps I could say it, a critique that I've gotten from my blog posts and some of my content is it came from a psychiatric nurse who wrote to me that he doesn't like the content the way I'm talking about psychiatric diagnosis, because it's not a big deal for the people who are like doing the treatments, like the doctors and nurses. Like it doesn't matter to them what the diagnosis of the person is. And I have to say, I keep hearing from people very different story, and I've experienced it myself. And I do understand that it's not like very important for every one of them, but there are so much about this this idea that when you have this certain diagnosis, there can be very like normal goals or normal things you want in life, like getting back to studies or getting back to work or anything like this, like getting a family. And these can sound kind of an unrealistic with certain diagnoses. They can start to sound like you have unrealistic expectations of what your life can become. That's one of the things I've like clearly seen. And another thing is that I don't think that these people in the field necessarily understand how big part of a person's identity this diagnosis can become, and how big part of their life that can become, and they have no idea that like there isn't this basis for using these, and it can also like direct what we are helping, like how we are helping the person. If we say to them like there's not very much anything else to do than to take your drugs, and like you're not suitable for psychotherapy because you have this kind of diagnosis. For example, for me, it was I was told that like psychotherapy wouldn't help me. Like my problems were so serious that psychotherapy wouldn't help me. So it's there's no point in like trying to get to psychotherapy. It makes no sense. But with the diagnosis I had, that was the point of view of that psychiatrist at the time. And something else too. Oh yeah, one of the things that I think we could do in this current system, where we do need this diagnosis for people to get a like certain benefits or some kind of other things like getting psychotherapy or anything, we could talk about it as a tool in this current system, not as something that people have. Like from these like in this current system, we could talk about this, for example, like this. In this current system, we need to name, like we need to give you a diagnosis for you to get certain benefits. And in this situation that you're in right now, from these options, we could perhaps use this diagnosis for this specific purpose, not as something that you have, like you have this generalized anxiety disorder, or you have this depression, or you have this like it's a characteristics of the person. We could name it specifically that in this current system we do need to give this diagnosis for this specific purpose, and from these options this is something we could use to describe your current situation. That's a totally different thing, in my opinion, than to say that you have this diagnosis and you have this disorder. So I think I'm okay with using the diagnosis in the current system if we talk about it properly and don't tell people that you have this thing in you that is like this kind of illness or disorder.
Yeah.
So that's one of my.
We could just be honest that it's our best attempt to describe it. We could call it a descriptor, couldn't we, or a label or something.
Yeah, and one of the things, current situation. Like not like this, because it's so easy to for it to become this kind of a lifelong thing. So I think we could say it very clearly that this current situation, and keep the option open for things to change, for life to change, for the situation of the person to change. It's not like it's characteristics of the person. One of my pet peeves.
Indeed. And I remember when I worked in America, a lot of us used to use it because you have to have a diagnosis to get insurance. It's an insurance-based system there. We all used to use adjustment reaction because we thought it was the least stigmatizing possible thing, a temporary adjustment reaction. And to explain to clients why we were doing that. Eventually, so many people started using that the insurance companies stopped. They wouldn't accept that diagnosis anymore. So yeah, I mean, it's how you use it, how you explain it. So yeah, not creating this illusion that you've actually explained something, and if this is something inside somebody, especially to be saying this is something you've got permanently. That's negligent, I think, to say to somebody, you've got this thing, and that means you're never going to be able to do this or that. You're never going to be able to benefit from psychotherapy, and then wonder why the person doesn't get better. I mean, come on. That's the blindness sometimes of the effect of their behavior on that person. Because again, it's a perfect example of ignoring the social context, because they are part of the social context. They are this very powerful piece of your social context at that point in your life. And this bit of your social context is telling you you're never going to get better. The expert that we're going to believe. And that's, I hope that's happening less and less over time as people are beginning to figure out how debilitating that can be and how irresponsible that is to lock somebody into that perception of themselves as somebody who's forever going to have to lower their life expectations. That's just, I think that is happening. I don't have any evidence for that, Peter, but maybe it's just a hope that it's happening. If it's all right, I'd like to move on to the one of the biggest disadvantages of this, which is stigma. In a way, we've just been talking about self-stigma, I think, haven't we? As sort of things people tell themselves as a result of the diagnosis. You could call that self-stigma. But I want to talk more a bit about how other people react once you diagnosis, and it's not good news. I mean, there is research showing, again in my field, psychosis and schizophrenia. There's research showing that for some people, quite a lot of people, the reactions of friends and family and public through the diagnosis is worse, has a worse effect on their life than the problems they had in the first place that got them the diagnosis. That's how strong, and maybe you have some examples, I don't know, but so once a diagnosis is applied, and if other people get to know about it, I mean, there is some sort of systemic discrimination in terms of employment and renting houses, and that's I'm traveling from one country to another. There are still some countries that if you tick the box, you've got a mental illness, you can't get into the country, or etc. etc. And so there's those sort of systemic biases, but I'm talking more at a sort of interpersonal level, perceptions of the public and family and friends. So if you've got a diagnosis, the first thing it does, or one of the main things it does, is, as we've talked about, once you've got a diagnosis, that implies a medical explanation, something wrong with your brain, basically, is something biologically, medically different about you from other people. So it increases the perception that a person is unpredictable, that they are not responsible for their behaviors, increases the perception of the severity of the problem. Pessimism about recovery, so this idea that the person is never going to get better because they have this diagnosis, they have this thing inside them that's permanently going to be there. And then perhaps the major ones, that increases perceptions of dangerousness, so increases fear and desire for distance. And those things together are very, very powerful for it. So it's a little bit like, and this is particular within psychosis, but a lot of these things are relevant for other diagnoses as well. But schizophrenia is the most stigmatizing, I have to acknowledge, but others are also stigmatizing. So it's a little bit like, hello, I'm John, I can be dangerous. There's no way of knowing when I'm going to be dangerous, violent, and when I am, I'm not responsible for my behavior. Can I be your friend? Will you give me a job? Can I babysit your child? And these are very, very powerful perceptions, which are repeated in studies all around the world. And the classic experiment is, if you describe somebody or show a video and you give two explanations, you give the psychiatric diagnosis explanation with the biological factors involved, or you say this person has just been through a crisis. Their mum just died and they saw a car accident or whatever, and the attitudes are massively different. People do not feel scared of or distant from somebody who's can be very, very upset, but they can see there's a social cause of it, because they can see, well, I would be upset too. So they're very powerfully stigmatizing these labels, and can really have a debilitating effect on people. So that's why I think apart from the lack of science, I think that people should be really careful before they assign these things to people. And as we said, then especially the pessimism about recovery aspect of it, and you wonder why people don't get better. It's a self-fulfilling prophecy that these experts are actually instilling into people unintentionally. It's all well intentioned. I've got to be clear about that. People are generally trying to help, and they're trying to explain to people what's wrong with them. And as we said, short term maybe it helps, but long term usually not.
Yeah, A couple of things that popped into my mind. First of all, I remember getting a message on Instagram from someone who said that, like, yes, I know I have this depression diagnosis, but I wish that my like friends and family would understand that I can sometimes be frustrated just because I'm frustrated and something happened. It's not a sign or a symptom of this depression. And also the even more sad part of this idea, I think, is that it can allow other people to even abuse people in some situations, because they can always like go back to this. No, you're not understanding this correctly, because of this is part of your illness, you know. And even hearing from people who have a psychiatric diagnosis, and they keep telling the doctors and the nurses that you're not listening to me, you're not understanding me. And that's also can be seen through this lens, like, oh, you lack insight, you don't understand your situation. And there are so many things that are I think very disturbing to experience as a person. Like there's one thing to have struggle in your life, and there's another thing to have other people tell you that your struggle is not what you think it is about. Like, we have a problem in this relationship. It's suddenly it's not about the relationship. It's about your illness. So there's I think there are many cages in psychiatry, and one of them is that we start to see things through this lens, and the person can feel very restricted because they have struggle in life, but in addition, even more struggle in life because they are not heard, they are not listened to, they are not seen the way they would prefer. And I was talking with a friend of mine who had been discussing this idea of schizophrenia with other people, and the comment that she got was that it's very difficult to think that schizophrenia wouldn't be an actual illness and a real diagnosis, because these people are so similar. Like, I've seen this commenter say that I've seen so many of them, and they are so similar that it's very difficult to experience, like, or think about like this not being an illness. And here's another danger, in my opinion. We don't necessarily see if the similarities are because of the so-called illness, and this illness we see in this person, or if it's the effects of the treatments, like antipsychotics, these neuroleptics. What are we seeing? Are we seeing the common effects of these medications that we give, or are we seeing the common effects between people who have this label? And I think this is one of the unfortunate things as well. And because we don't have the objective like metrics or anything that we can measure, like blood levels or anything, it's so easy to think that, okay, this person has depression, we are giving them treatment, and suddenly they get more psychiatric symptoms that can be labeled as psychiatric symptoms. And we don't necessarily see that they might be side effects, they might be adverse effects from the treatments. So we end up in a situation where this person at the beginning had this label depression, and then we end up with different diagnoses, and we see it as, okay, now we are getting a more accurate picture of this person. We are getting a more accurate diagnosis. And it's not anymore depression. Like for me, it was at the beginning, it was depression. Then it started to get worse, and I ended up with a schizoaffective disorder. So I think this is one of the unfortunate things also, that we don't notice when we switch or shift from the path of treating an illness to treating the effects of our treatments, if that makes sense. It's yeah. I think that's one of the issues that I have, because we don't have anything like any way to measure. So we can end up with person with a depression gets a bipolar diagnosis, and it's not necessarily that we revealed this bipolar diagnosis just revealed itself, and now we know what it really is. It might be an effect of the treatments that we're giving them. So it's one of the unfortunate things.
Yes, I mean, one of the biggest examples in psychosis is what they call negative symptoms, which is just to explain briefly to viewers, negative symptoms are the absence of absence of feeling, absence of social life, absence of just a sort of flatness, and anhedonia, lack of ability to experience any happiness. That's exactly the effects of the antipsychotic drugs. That's what the antipsychotic drugs do. They're very powerful tranquilizers. So it's almost impossible to tell the difference between a negative symptom and the effects of the drugs. And you also mentioned lack of insight there. That's one of the things that makes me most cross. Because if you're trying to explain to your doctor that I don't think I've got an illness, doctor, I think it's because this happened to me and that happened to me and so forth, that will be seen very often as lack of insight. And that is a symptom of the illness that you say you haven't got, but the doctor says you have got. So the more you try and explain, the more the doctor is convinced that yes, you definitely are, and you can't talk your way out of that.
Yeah.
That's like an absolute double bind. And we put the power differential in there as well. It's really, I think that's quite unforgivable to tell people, if you disagree with me, they're basically saying, if you disagree with me, that's a symptom of your illness. I mean, that's not okay to do that. I did want to just throw in there that sometimes people who are listening to a conversation like this will say, oh, Pia and John they're saying these things don't exist. Don't they get that people really are struggling? So just to clarify, when I say, you speak for yourself here, but when I say schizophrenia does not exist, I am not saying that people don't hear scary voices, that they don't sometimes get very paranoid. I've worked all my life with people much of my life with people like that. So of course I understand that these things are happening and they can be very, very upsetting. All I'm saying is that lumping all those things together and calling them something doesn't help us understand. But neither of us, I'm sure, are saying that people don't have very disturbing. We're just saying that the labels don't help. I just thought I'd clarify that, because that's one of the common sort of responses. So just worth clarifying. Should we say something about the current, what's the right word? Current trend towards lots of people getting diagnosed with ADHD and that sort of thing, because that's kind of a big, odd not to talk about that since we're talking about diagnosis, isn't it? Well, just to clarify where this has come from, in the last, the DSM has had 5 versions starting in 1952. Up until when this last one was introduced, the first one was about 100 pages. This one is now 964 pages long. And as I say to my students, if you can't find yourself in here 3 or 4 times, you really need to get a life, because we are all in here many times if you go through it. I'm not going to say what mine are at the minute. But the point is, up until 2013, ADHD was a disorder of childhood. And one of the many changes they made in DSM-5 with no scientific basis to it all, they just voted to decide that, it's now a disorder of adulthood as well. And many quite senior people at the time pointed out this is going to lead to a massive number of people getting an ADHD diagnosis and using that to explain all sorts of things that have gone on in their life, and a massive increase in the use of ADHD drugs like Ritalin and so forth. And that indeed is exactly what's happened in Britain. Our mental health services are absolutely swamped now. There's a waiting list for people to get an assessment, to get a diagnosis of ADHD. At universities, including where I work, we've got somewhere up to 30–40% of students saying they've got some version of neurodiversity, like ADHD or autism or whatever. And again, I'm not saying that the people looking for these diagnoses have not got some difficulties, but there's two questions to address them. The vast numbers of this newly created disorder, adult ADHD, one of the problems or issues is that it's not going to be possible to provide any services to that number of people. So the people with really severe problems, like autism, for instance, and it is one that has a biological basis, but that's a different issue. I think there's a problem with services being steered away from people who really, really urgently need them because of severe problems, with people who are got some problems and are seeking to find an explanation for them in a label. And I'm going back to what I said right at the beginning. That can be really reassuring, really comforting. Now I know why I can't concentrate in class, or why it takes me 3 times longer to write an essay as my friends, or all of those things. We've got an explanation for it. And if it helps, and it helps the person feel better, fine, no problem. The other problem is that there's a lot of people getting diagnoses online, or with people setting themselves up in business to give these diagnoses and very brief assessments, and that's really, really problematic. And the whole concept of neurodiversity I find difficult, because I don't know what the figures are now. It depends how you define neurodiversity, but the numbers are massive. It's almost getting to the point where there's more people with neurodiversity than people without neurodiversity. So what on earth does that mean? And why can't we talk about diversity without neuro being in front of it? Of course, we're all different. I think we all have our weaknesses and difficulties and things we're not very good at and things that upset us. Are they all an example of being neurodiverse? I'm not sure they are. I think they're a sign of us all being diverse and different, and some people having more struggles than others. But I think it raises a lot of questions. And I'll just give an example from university, and then I'll stop. We are bending over backwards at my university and other universities to make accommodations for people who have got these new diagnoses of neurodiversity. And I think that's okay up to a point. I sometimes wonder when a student says, I'm too nervous to give a talk in class because I'm neurodiverse. If we say, okay, well, you don't have to then. Are we not locking them into 50 years of never being able to give a talk in public, versus, okay, how can we help you with that anxiety? How can we make it a bit safer? Can you do it? Should we do a role model one-on-one and practice, or whatever, trying to help people solve the difficulties that they're saying are an example of their neurodiversity and that they sort of feel that they're stuck with. But they've now got an explanation for it, so they kind of don't need to do anything about it. It's a whole range of, again, it's a range. Some people are using the diagnosis, well, now I know what it is, I'm going to do something about it, I'm going to get some help with this bit of behavior. And other people are going, oh, well, I don't have to worry about that now. That's who I am, and I just can't do those things. So I think it's more complicated. It's very controversial as well, because having said that, I can immediately be attacked for, oh, you're one of those people who wants to cut back on mental health services, are you, John?
Yeah.
And I don't actually mean that. But yeah, it's complicated. What do you think about it all? What do you make of it all?
I think one of the things I think that makes it so popular today to get these diagnoses might have something to do with it gives an idea of community, of belonging to some common community.
Yes.
And I think that's maybe one of the reasons that people want it. Like, I'm part of this group, and that's something I feel that many people are missing today in our daily lives. So it's like, I'm part of this community,
especially online, I guess.
Yeah, especially online. Yes. So I think I'm thinking along the similar lines. Like, we have these, they can end up being self-fulfilling prophecies, for example, that we're starting to say that I can't do that because I have this thing. And we don't notice that there can be, for example, skills or something we can practice that can help us with our, for example, with the speech example. Like, I can practice doing public speaking, or I can practice explaining myself, whatever it is. I can practice. Like, there are so many skills we can learn if we think about them as skills, and it doesn't necessarily it's not necessarily as helpful as people may think. that to get a diagnosis and to get a sort of explanation that seems to be explaining. And also we can end up categorizing ourselves and choosing the language we use to describe ourselves according to these descriptions that are visible in the diagnosis. So perhaps it's not so easy to recognize when we are putting ourselves in a certain box and describing ourselves in those terms, instead of seeing that we're different, we're diverse, without the narrow part. Yeah, that's my thoughts on it.
Yes, that makes sense. Yeah.
Yeah, I have, we're running out of time today, so I'd like to make a couple of book recommendations for people. I highly suggest that you read about these things. Here's one, the Power Threat Meaning Framework as an alternative to this diagnostic system today. That's very good. There's Lucy Johnstone's Straight Talking Introduction to Psychiatric Diagnoses, and this book, Drop the Disorder. And I think Drop the Disorder also has a Facebook group and YouTube channel also, and very, very good content on those as well. And I think we can talk about the alternatives for in the further down episode about alternatives to coercion, and perhaps we can touch more on the alternatives in that episode as well. For example, the Power Threat Meaning Framework, which I recommend people to read about. It's very different approach, and I find it a much more helpful approach than this current diagnostic system. Our next episode will be about antidepressants, and in March, I think we'll record that episode. So I'd like to say thank you for our viewers and listeners. And if you feel that this is important to talk about and important to people to listen to, please share this series with your friends and tell anyone you meet about this series, because I think this is very important to get people to think about these issues differently and spread the word about this different way of looking at human suffering. It is suffering, but it may not be as useful to call it with these diagnostic labels and so on. Anything you'd like to add, John?
No, I think that's a good summary. There are alternatives, and we'll talk about them another time. So I just want to say thank you for organizing these, Pia, and I really always enjoy them a lot. Thank you.
Thank you for being here with me to talk about these issues, and we'll meet again.
Bye-bye.
Okay, bye-bye.